when you're on hospice and you're getting hydrocodone, Xanax, whenever you want it, whether it's to numb the mind, the pain, just laying in bed all day sleeping, how is that any different than patient wants and let's just go quick rather than drawing it out? It's not for me to decide what's right or wrong.
If you are an individual that is suffering and you would like to refuse treatment that ultimately results in your death, that's okay. You can always refuse the treatment. But those individuals that are suffering in the same manner, that are not hooked up to the medical devices that are help keeping them alive, they don't have that same option.
Medicine,
law, friendship. This is Dr. Long and Lawyer Nik. You're listening to the Medico-Legal Brief.
one doctor, one lawyer, and a whole lot of gray area.
Welcome back, everyone. It's another episode here on the Medico-Legal Brief. I can't believe how routine we've been on this and how many episodes we've already put out.
Yeah, I know. I think this will be at least 10 plus at this point.
Yeah, at least 10 or plus, depending if we move around some of those episodes. But I wanted to start today with a different type of segment. It's a new segment that I thought of and Lawyer Nik has approved. I want to give you 3 options and I want you to choose, and I will give you a medical story revolving around that. So you get to choose between a good story, a bad story, or a crazy story. What have you?
Our topic today is a pretty heavy topic. I think what I'm going to go with is the good.
All right. So I've got a feel-good story. And the feel-good story starts with a cute little family. I'm starting in my new practice. Family comes to see me. And initially, it's just the mom, right? She is young. She's in her late 20s. And she's just trying to establish care. We're currently living in rural Wisconsin at the moment and rural Midwest. The family unit is actually surprisingly close. They have uncles, aunts, grandparents, all living in a vicinity of maybe 10, 15 miles away. Their family unit is very strong. Throughout this whole conversation, she seems pretty closed off. She seems like she's answering yes and no answers, but she's not really giving me more story as I try to dig and kind of pull it out of her, right? I'm trying to get to know her a little bit better, build that rapport. As we're talking and having that conversation, her 2 kids that she has there with her are running around, playing around, jump around, just as kids are, messing around with things on the tables and can't sit still. Throughout that entire time, I thought that I was not building enough rapport. I thought this is probably not going to work out. She's probably not going to like the relationship that we're currently building. But to my surprise, this was actually just the start of what was to come, is that she ended up bringing back her kids. And then she ended up forcing her husband to come see for some medical issues that he had been putting off for years. What ultimately really solidified the relationship is that she actually got both grandparents on both sides, maternal and paternal, to come see me, as well as some of her aunts and uncles. And when I left this job, this was the one family that I missed the most. They showered me in so many good things when I left. Not only did they treat my staff well, but they gave me going away presents and just showered me in praise, which was really nice. That is my feel good story of the day. How you may not know when you're in that moment with the patient or with another person, how they're feeling about you, how they're feeling about the interaction, but you may be putting just a very profound stamp in their life that it changes it, and you're going one direction and then all of a sudden you're taking a different direction. That's my feel-good story.
So that's a very good feel-good story. That says a lot about you as not only a doctor, but also an individual, because in our discussions, you've obviously explained that you pride yourself on being able to build that rapport and take your time and really focus in on the patient's needs. That's one of the best compliments, is when you have your patient and they turn around, they start bringing other people in. It happens in the law too. You know, you're doing a good job when you start getting other clients because the references just keep rolling in. Good job.
Thanks.
Dr. Long.
And I'm glad you chose the good story, because it kind of ties into our conversation that we're going to have today, which revolves around the physician-assisted dying or physician-assisted suicide. It's a really tough and hard topic to have, but it's a topic that really holds true to that patient-doctor relationship, that if you have that strong of a relationship, that the patient is willing to talk to you about these really difficult conversations and thoughts that they may be having. If you want to kick us off, Nik, how do you want to start this?
Yeah. Basically, I live in Texas. Physician-assisted suicide in Texas is not a thing. And we studied a little bit in law school, just kind of looking at the nuances of somebody assisting somebody else in the process of dying. I want to establish a medical base. I know that you've lived in the Pacific Northwest, you've done schooling in the Pacific Northwest, and that's primarily where this started. Can you just break down physician-assisted suicide, all the nuances of what exactly we're looking at?
What most people know or have heard is the physician-assisted suicide title or name, but it actually goes by several other names or synonymous titles as well. Physician-assisted dying is also another term that can be used, or medical aid in dying is also another term that can be utilized in the same approach. There is a lot of nuance between what a physician-assisted dying plan looks like versus what sometimes we hear of from international countries where they are using euthanasia. The difference is euthanasia is another person ending the patient's life, whether intentionally, unintentionally, or without the patient's consent. Whereas with patient assisted dying or medical aid in dying, it is actually the physician providing a means for the patients to utilize themselves to end their life. There are a lot of criteria that we will go into to qualify a patient to be approved for this. And there are a lot of hoops that a patient has to jump through, but also what the physician has to do and document appropriately before this can actually officially go through. It's not something that you make a decision on a whim, and it's not just a singular person that can determine whether or not this is possible or not.
To your point, like the slang term, the street term for it is physician assisted suicide. But in looking at the statutes on the books and the names for the regulations, the medical aid in dying, the MAiD has been predominantly the formal term for this process. Is that correct?
Right. I agree. And that's what I've seen too in seeing the different states and their rules and regulations around it. Majority of them, if not all, use that MAiD or medical aid in dying.
This kind of ties into when we were kids. There was like Dr. Kevorkian, and he was killing his patients, or at least helping them die in that manner. And that's kind of the first instance of people hearing about this. And to that point, it's more of like a criminal infatuation. You know how people are infatuated with like criminal cases and murder mysteries and the sort. I think that's kind of where it falls in. But this is a definitely a more serious concept and a more serious process than just tying it into, I think, the Kevorkian stuff. It definitely has a lot of political debate on both sides of the aisle, and it's definitely something that when you look into it, it can be very, very enlightening when you start looking at the qualifications and what these patients are going through as they're making the decision to do this.
But that's probably the most important thing we want to keep in mind as we go through this topic is putting ourselves in the patient's shoes, because we're never going to know truly how it feels to feel what they're feeling, where they're at in life, and what their options or resources are. When we have this conversation, it's not for or against this course of action. It's really just enlightening, explaining the process, just so that there's more information and knowledge out there for people to understand.
To start the breakdown of it, where is this allowed in the United States? And then after that, what are the overall requirements that's pretty consistent across all these jurisdictions?
There are only 11 states that allow this MAiD. I'm going to keep it short, MAiD process to occur, but there is also Washington, D.C. So that is technically 12 locations that are allowed. And I can name them very quickly. They're going to be in California, Colorado, Delaware, D.C., Hawaii, Maine, Montana, New Jersey, New Mexico, Oregon, Vermont, and Washington. Those are all the states in D.C. that are allowed. The criteria, again, there's a laundry list of criteria that a patient needs to meet before they are allowed to even consider this. One is they have to be over the age of 18. Two, they have to have a diagnosis that has been given to them that has predicted or prognosis of less than 6 months to live. Going back to that definition episode, diagnosis is terminally ill diagnosis, as well as a prognosis of less than 6 months. The diagnosis should be a chronic and or life-altering condition that is irreversible. They must be of sound mind. They have to see a counselor or therapist, usually, or psychiatrist, to determine, to make sure that is the case. There should not and cannot be any other psychiatric disorder, whether that is untreated depression, bipolar, any other things that can confound the decision making. So again, It reverts back to that psychiatrist, therapist, counselor that will help determine that factor. And finally, once they have met that criteria, for them to actually start the process, they have to have two completely separate physicians make a determination whether that is appropriate. Two doctors have to then agree. They don't talk to each other, but they have to agree that this patient does have that terminal illness and that they only have 6 months to live. The patient then has to request either orally or in writing, dependent on the state, to start the process. And then they have to give the same oral and written process again. They have to request it twice within a span of usually between 2 to 3 weeks apart. And the reason that the majority of these states require that is because you want to make sure the patient doesn't change their mind. A span of 1 to 3 weeks, it gives the patient an opportunity to maybe second guess their choice or their decisions, change their mind, decide against it or not. And again, there are a lot of safety guards in place to make sure that if this is going to be allowed to go through, that the patient is making it with their best intent and their best in mind.
I think one of the things that stands out there, and we've talked about this before, but in the realm of contracts as well as in the realm of medical capacity, is the competency part of it. One thing that stands out, and I actually, in my own research, I saw that the mental illness aspect of it is a very, very big process or I guess a very, very big point of debate, especially in Canada. And being able to ensure that the individual is competent is extremely important in these scenarios, because if the competence isn't there, either because of, a mental illness or what have you, then it kind of debilitates the entire argument of why you need this, because you're not sure if they're competent enough to even make the decision.
Correct. Correct. And again, that's why it's not a process or a decision that's made lightly. It's not something that you wake up one day and you decide. It's actual several months to finally get through to the end product where you are given the medication to end your life. It's several months process. You're seeing multiple different specialists to get approval before everything goes through.
Now, another question for you as a physician: when we're looking at defining something as a terminal illness, eventually we are all going to die. We're all going to pass away. But with a terminal illness, is there a requirement that you are, this diagnosis is going to lead to your death in a year, 2 years, 3 years, 4 years, 5 years? I mean, how do you define what is a terminal illness?
And that's the subjective part. It's hard for physicians because that's the first thing that anyone ever asks when they get diagnosed with cancer is, how much longer do I have to live? And that, unfortunately, is not an answer that physicians nowadays can answer. We usually give a very neutral answer, which is, we can expect you to live this long, but you could go sooner, you could live longer. We have no idea. It's really out of our hands. But these are the risk factors that you have. These are kind of what your labs are showing. This is where your vitals are. This is kind of where your current health is. And then that's what we mark against what we've seen in the past. Patients who've had these numbers tend to die more quickly or deteriorate more quickly, versus people who have this condition, tend to survive longer or do better with this. There's just so many different components to consider that usually when you're deciding if a patient has a terminal illness, that's why this requires that you have two physicians, so that you have two different perspectives coming down to the same conclusion.
Now, I also wondered at that point if an individual can physician shop. We've talked about, shopping for expert witnesses, trying to find the individual that's going to give you the answer that you want. If you were to go to physician A and they said, yes, you meet the requirements, and then you go to physician B and they say, no, I'm sorry, I'm not going to sign off on this, is there a path where you can then go to physician C and then say, actually, I'm going to sign off on this because I agree with physician A?
I'm sure you can, and that is probably a loophole that could be utilized. But there is another component that is recommended, especially in states like Oregon, where they have thoroughly reviewed the process, is they don't require it, but they recommend that you notify your next of kin of your decision. That helps throw in another, again, not barrier, but another hoop to make sure that all bases are covered and that people understand that you're making this decision and that people around you are in agreement or not in agreement, so that you guys can have that discussion together. But yes, I mean, I don't think that there's any sort of legal ramifications for doctor shopping. Like if you went to 6 different doctors and you've got 2 of them to agree, then you meet the requirement.
How do you define if there's anything in the medical field that can then help the individual get through, their diagnosis? So if is there experimental drugs or there experimental procedures, if those are kind of ancillarily available, does it still impact whether or not you can define somebody as terminal or that they have 6 months or less to live?
If it's an experimental drug that we're looking into our trial, we cannot say that that is a treatment. We cannot guarantee that it's going to be a fix or a cure. Well, whatever diagnosis they had is probably still considered terminal. And the reason it's termed terminal is because we don't currently have a treatment plan for it. It's very hard to get a terminal illness. It's not something that we throw out very easily. I think as medicine advances, it's becoming harder and harder to get that terminal illness. But ultimately, we all have that terminal illness of aging. We're all going to eventually die. But it's whether or not we have a lot of other comorbidities that is going to push us quicker and closer to that end than we realize.
That makes sense. Do they teach you any of this in medical school? I always ask that question to you because a lot of these topics are very important topics. And we've talked about this with medical malpractice and physician employment contracts and what have you. But do they give you any sort of feedback or history on this process?
They do not. Again, through medical school and residency, our only goal is to learn the medicine of it all. Learning the science, learning the medications, the pathophysiology, how diseases work, how to treat them. We don't talk about the legal, real life interactions and ramifications of our decisions. That is something that you have to obtain as you grow. It's something that you obtain as you go out there and you practice and you experience it yourself, and then you do your own research and you reach out to an attorney buddy like Lawyer Nik, so that we can have these conversations and do a deeper dive so that we can understand the processes and utilize the resources that we have available to us and to our patients.
When you're looking at states with their own, let's say, legislation on the books regarding MAiD, and you had mentioned the 11 states and the District of Columbia, when you're looking at your medical boards or your medical communities, your hospital communities, or your healthcare providers, are there any policies or procedures that can kind of go for or against that? Because we've talked about private practice, right? Private practice versus corporate practice. There has to be some sort of policy that healthcare providers can lean back on and say, hey, in our health system, this is not allowed. Is there anything that exists in that manner?
If you're focusing on the health system, no, nothing in that layer. Everything that is policy within the health system or the hospital system is trickled down from those larger entities like the state legislation and the state legalities. And then even higher would be the federal legalities. Everything that occurs up top then trickles down, which then determines what the policies of the hospital systems and health systems are. If we wanted to talk about abortions and vasectomies and things like that, they are not hospital dependent, whether that they can do it or not. It's state dependent first, unless there is an overarching or an overruling by the federal. Everything that occurred after Roe v. Wade was overturned, that trickled down to the hospital system. And a health system cannot then go against it. If a state does not allow physician-assisted dying or MAiD, then no hospital is going to be allowed to approve that process.
That's something I never really thought of until this conversation. That happens a lot in these podcasts and these conversations with you, is the thought of, as a business, you can choose to do business the way you want to do business as long as it is meeting the guidelines of the state or federal law. It's not discriminatory, those instances. Well, hospital systems are businesses. It's interesting to hear that a business that is the hospital can't put their own spin on things. If your hospital business does not agree with abortion or does not agree with vaccines or does not agree with certain treatment, they still have to adhere to the law and administer it without saying, no, we're just not going to. I think that's really interesting.
Correct. There are nuances, though. If there's a religious body, they can always say religious exemptions. They're not going to allow this or not going to approve this procedure. That you can see quite a bit. But again, as long as that there are resources that they can offer, patients can go elsewhere, then all is fine.
Leading into the discrepancy between MAiD process and the euthanasia process. So from what I understand, in the MAiD process, the doctor prescribes the end-of-life medication. The patient goes and picks up the medication. They go home, they determine the time and the date, they administer it themselves, and that's how that process is conducted. But when we're looking at euthanasia, can you explain to listeners what the nuance there is?
I don't think there's too much nuance in euthanasia. Euthanasia is just a provider, someone that has the capability of giving a life-ending medication to a patient. That's where it gets kind of muddy, and that's why this topic is controversial. And that's also why euthanasia is not at all legal in any state here in the US. But it's the provider giving a life-ending medication to a patient. Usually it's a patient that is suffering, but you don't necessarily have to get the patient's approval or their consent is what I'm understanding when I'm looking at the international laws and legalities around euthanasia. And again, internationally, there are very few countries that still allow it.
That's also a very interesting point in the sense that a patient can decide to refuse treatment that leads to end of life, but they can't ask for treatment that, besides the MAiD process, but they can't ask for treatment that results in end of life. Does that make sense?
And that's the nuance. That's always something through our history we see that there's that struggle. There is almost hypocrisy that you are allowed to do one thing but not allowed to do another thing. You can have autonomy of your body to a certain extent, but not fully. It's a very interesting topic, and yes, this falls well within that very polarizing conversation.
That's kind of what leads to some of these statutes being put on the books and the legislation regarding MAiD. If you are an individual that is suffering and you are at your end of life and you would like to refuse treatment that ultimately results in your death, that's okay. You can always refuse the treatment. But those individuals that are suffering in the same manner, that are not hooked up to the medical device that are help keeping them alive, they don't have that same option. That's what encourages some of the discussion around being able to have access to, end of life assistance, that medical aid in dying. And I thought that was extremely fascinating, trying to look at the nuances between the two.
Another thing that Oregon specifically requires is that the physician, when having this conversation, they should be offering other options. So yes, you have a terminal illness last 6 months, but guess what? We have chronic pain management specialists that could potentially help if it's pain related. We have palliative care, which is very similar to hospice, but those two, palliative and hospice, kind of go hand in hand. One is end of life, like all you want to do is just make sure you are comfortable. Those are other options that you should offer the patient and have that conversation. And that's where it becomes really interesting, that what's really the difference when you're on hospice and you're getting hydrocodone, you're getting a ton of Xanax whenever you want it, whenever you feel like it, whether it's to numb the mind, whether it's to numb the pain, whether you're just going to be laying in bed all day, all night, sleeping. How is that any different than what a patient wants when they just want to end it, period? Let's just go quick rather than drawing it out. It's not for me to decide what's right or wrong, but it's that nuance that it's interesting that when we look into the legalities of things and how patients and physicians are reprimanded for trying to go through this process to help their patients. But I also understand the other side of it, which is how do we truly know if a patient is of clear mind at that moment in time until the very end, but also are they being coerced by anything else? And whether or not, what if they held out? What if a new treatment does come out that last month before they decide, before the end of their life? What if something does come up and could fix them or cure them or improve their life that could change their mind? There's just so many components and so many moving parts that that's why it's such a hard conversation.
It's kind of wild that an individual could be going through the process. They have less than 6 months to live. They're terminally ill. And I'm sure, and you can comment on this, I'm sure that some of these terminal illnesses can cause an individual to lose their mental capacity at some point within that process. If you spend the first 2 months going through the process and all of a sudden that third month, your counselor, your physician, or whoever you're speaking with says, actually, hold on, pause. The mental capacity may not be there. I'm sure in those jurisdictions that immediately stops the MAiD process. And now you have to revisit competency, and somebody who maybe as a competent individual with the mental capacity who wanted this, they can no longer get the assistance because they are deemed not competent. You can write in your medical power of attorney, or you could write in your do not resuscitate. They can make the final decisions as to what happens at the end of their life if they're in that situation, but the capacity kind of drives the ability. If they can't do it before the capacity is gone, then they're kind of stuck in this incapacitated terminal illness, and there's no solution to that other than kind of living it out.
Or is that us harming the patient in a way? That's where people fall on either side, and it's hard to decide and determine. And I don't think anyone can decide or determine that, officially.
Yeah. And I'd be interested to see if after that point, if a medical power of attorney could then come in and continue that process. Because from a medical power of attorney standpoint, you are now standing in place from a competency standpoint of the patient. So then could you continue the process? That might be something that we look into. I know we're going to get to the legal, but I had one big question for you. At the beginning of the podcast, you had mentioned being able to put ourselves in the position, in the shoes of the patient. Unless you've experienced somebody going through end of life or going through hospice or a terminal illness, you really don't understand what that looks like. From your point of view as a doctor, seeing individuals dealing with those types of illnesses in hospice, what is it that you see the individual go through? What does the patient go through on a daily basis that may make it a struggle to continue living?
Well, it depends what the illness is. Is it an illness
Yeah.
that causes physical disabilities? Are they not able to get around? Is it something that causes severe fatigue where they can no longer do the things that they love? Are they an artist that no longer has the ability to use their hands to draw? It really is so individualistic. And that's why it's important that you get two physicians to sign off on this, because everyone's going to see it a little differently. And it's interesting because you're right. I said that you got to put yourself in the patient's shoes, but as a physician, you also have to be as non-biased as possible because you're making a decision that should be a neutral decision based on just the facts, right? I should not be swayed by emotions, by the relationship we have. I should be making the decision that is the most beneficial, or what I think is the most beneficial for the patient, whether that is for their mental health, for their physical well-being, whatever it is. And if that includes the MAiD process, then it might be. But again, again, that's such a hard thing to think about.
Right. Like you're an individual, subjectively, an individual could say, I want to die because I can no longer do my passions, but it's more than that, right?
It's more than that. The difference between hospice and MAiD is hospice,
Yeah.
there's an end in mind, but the patient still wants to still be around, surrounded by family and friends. Whereas
Yeah.
MAiD is they just want to end it then and there. Like they just a lot more abruptly. And who's to say which side is right or wrong? I mean, they're both the ultimate ending. The final, not goal, but the final result is the same. Both patients are going to die, whether they're on hospice versus on MAiD.
And to that point, it's the dignity. I even think that some of the acts are reference dying with dignity, not having to go through the process where you can no longer get up and walk, not have to go through a process where you can no longer swallow, or the pain is so aggressive that you're miserable every day, or you can't make it to the bathroom on your own. Like that's probably some of the aspect of the MAiD, is being able to die with dignity instead of going down that path of, just the stuff that you don't want to see, the stuff that you don't want to
Sure.
experience, and also putting your loved ones through the process, which they have to see you as the individual going through the end of days, which can be hard on family. I mean, death is
Yeah.
always hard regardless.
And the other perspective on that, though, is you do have to keep in mind the living after a death. The family and friends still have to go through their process of mourning and processing what is occurring. But for someone to go through MAiD and have such an abrupt stop, is that enough time for the family and friends to process, to move on from there? Or are they always going to have some lingering thoughts? Whereas hospice, usually, not always, usually it allows time for everyone to understand, oh, this is the patient, this is their loved one, they're slowly deteriorating. They can see it physically, they can feel it, it's tangible. And then when they pass, it's almost kind of like a relief. Now they're no longer suffering, they're gone. Versus MAiD, where it's just such an abrupt, one day they're here, the next day they're not. They may have had the conversation with the family, this is the decision that they wanted all along. But still, I wonder if there's support for the family once a patient has gone through MAiD.
It's something to definitely consider, because from a legal perspective, this should happen at the earliest point in your life when you're over the age of 18. But you want to go out, you want to get your will, you want to get your affairs in order. You want to make your passing as easy for those around you as possible. And I don't mean in the sense of actually passing away. I mean in the sense of having your affairs in order, having your assets in order, having a will, if you're leaving behind children, where your children are going to go, how are they going to be taken care of, so on and so forth. Because most of us don't know when we are going to die. However, from a MAiD perspective, you get these pills and you get to make that determination on the day and time of when you are going to die. That could allow you to get all your affairs in order and be prepared for the passing and have funeral arrangements already made. Your family understands what's going to happen, although they might agree or disagree with it. They know that the process of passing starts now, and now we have to begin that process. When you're going through hospice, you might never know. When you have a terminal illness, you just might never know. It could be 6 months, it could be 7 months, it could be 8 months. Maybe they're trying to limit the surprise factor and choose that date as well. Just different ways that I guess consider it from a legal perspective, having your affairs in order down to like the day, which a lot of people might find comforting, especially the type A's like us, the control freaks that, want to really control every aspect of their life and leave their family and friends in a good place.
With this conversation, though, I'm curious what you saw or what you read up on in terms of the ramifications and legal ramifications that would occur for physicians who practice in states that do allow it, or versus physicians in states that do not allow it. What did you say?
Basically, when we go back, this MAiD process essentially has been around for almost 30 years. It started in Oregon, and there was a Supreme Court case, Vaco v. Quill, which I hope I'm saying that first name right, where the Supreme Court of the United States determined that there's no constitutional right to physician-assisted suicide. There's a lot of, hey, this is my constitutional right, I should be allowed to die, or I should be allowed to do this, or I should be allowed to do that. But what they did do in that case is they left the regulation to the states. So each state, based on that Supreme Court case, could decide how they want to approach MAiD and physician-assisted suicide, physician-assisted dying, however you want to phrase it. That's the legal nuance a lot of people don't understand, especially when it comes to Supreme Court cases. The Supreme Court may make a ruling that says, hey, at the federal level, at the Supreme Court level, we are not going to make an overarching ruling that may impact the law or statutes. We're going to kick it back down to the 50 states, and all 50 states get to decide how they're going to approach it, which could be a good thing in certain instances because it allows that demographic and that geography to pick what's best for them. You go vote for the people that are in your state to make decisions and pass legislation that is in your best interest. It's why you don't want people in California voting for what people in New York should be doing, what people in Illinois should be doing, what people in Louisiana should be doing, because they're all different cultures and different demographics. So the Supreme Court in that case kicked it back to the states, and that's where we get the 11 jurisdictions making their own decisions. Now, as far as the states that do not allow it, what I found was there's a lot of criminal liability, there's a lot of civil liability, and then you also hit professional discipline, which medical malpractice, board discipline for doctors. When we're looking at statutes and legislation, each state can put on the books something that is very dialed in to what they want or do not want. Some states actually have laws that lay out what physician-assisted suicide is, what physician-assisted dying is, what euthanasia is, and on the books, it will say, if you are a physician and you do A, B, or C, you are guilty of this, and that is the criminal statute. Other states might be a little bit more broad, where it's just, if you are an individual that causes the death of another individual, there's a criminal liability. You can get really specific or really broad, depending on the language of the statute.
And so then how about if I think of a very specific case, patient is right of mind, they have gone through the process, they have been approved. And I know that there are 2 states that will allow non-residents to travel to their state to go through this process. What happens to the people helping those patients, whether that is a family member transporting the patient into the state to get the MAiD process started, or even the family member that picks up the medication that will then ultimately be taken by the patient? Do those ancillary people have any legal ramifications or legal, issues when it comes to the law and what federally and state laws allow? What do they
No,
what do they see? How do they see those people?
well, that's a very good question. Breaking it down from just putting my lawyer hat on, I would say first and foremost, you got to look at the state's laws. Are there any laws on transporting an individual across state lines to help them? Are there any laws on going to another state to get prescription drugs and bring it back? Let's say that one of these states that allows non-residents, I would assume that in that statute, that resident would have to go to that state and be in that state when the MAiD process is conducted and completed. I would think that if you had an individual go to that state and then bring it back, like in Texas, I believe it's a state jail felony. If I had traveled to another state to go grab the medication and bring it back from my family member, at that point, there's a lot of liability in assisting the death because it's not legal here. You're actually assisting somebody in killing them. But first thing you want to do is look at the statutes on the books. And then the other thing that is very interesting in law, there may not be a direct statute, but there could be a more broad statute where the statute may not state anything about bringing prescription medication to assist in killing somebody, but there might be a statute on transporting prescription drugs across state lines or bringing prescription drugs that aren't yours to somebody else to give to them. There could be statutes that are so broad that you can then find criminal liability under that process. That's a very good question. I think that when you're looking at the legality of it, first and foremost, are you in the state? Is there anything on the books about it in that state? And then could you be liable under another statute in that state? Although you may think that you're helping, you may open yourself up to criminal liability and civil liability.
When you were looking through this, did you find any standout cases where that was the issue, whether the patient themselves or an ancillary family member or friend was persecuted or was found liable for going through the process at all? Anything that stood out?
No, I didn't see any cases, and that doesn't mean that those cases don't exist. It just means I didn't come across any. The one thing that was consistent across the books in these states that do not have MAiD legislation is the fact that from a physician standpoint, you can be held liable at pretty much a felony level, and it could result in hefty fines and jail time. In some instances, if you were a physician and you helped a patient with their death, and even a MAiD process, not a euthanasia process, but a MAiD process where you prescribe medication, you can be looking at 15 years in jail in some of these states. You could be looking at $10,000, $20,000, $30,000 fines. And that's just a criminal aspect. Some states, like I said, have specific legislation that define it. Other states just put it under a manslaughter or a second-degree murder, depending on what's on the books for killing another in that state. And that's what's extremely interesting about it, that the ancillary individuals could also be part of that process and liability. If you are the doctor that's prescribing the pills and then you are the nurse that's sitting in the room listening to the doctor prescribe the pills, that nurse might be liable. If you are the person at the pharmacy knowing what's going on, wrote up the script and allowed it to be passed on to the individual, you could then be liable. It goes all down the lines. And we've talked about this before. When you're suing somebody from a civil liability standpoint, you sue everybody. If your loved one passes away from this and you want to have a medical malpractice suit, you're suing everybody. You're suing the hospital, you're suing the doctor, you're suing the physicians, you're suing the counselors, you're suing the DoorDash driver who somehow got the prescription drug to their person. Like, you sue everybody. First and foremost, the criminal liability would fall on the physician that is assisting in that process, and that opens them up to jail time. It opens them up to civil liability. Family members can sue. It opens up to medical malpractice, and ultimately opens up to professional discipline, where your license to practice medicine could essentially be revoked.
And this is why it's important that anyone that wants to go into the medical field, they understand all these responsibilities and nuances, that we're here to help patients, but helping patients may look differently to different people and to different patients. They have different expectations, responsibilities, and depending on the state you live in, they may support the physician a little bit more strongly or more positively than other states. It's very important to understand what you're getting yourself into, because these decisions are not to be made lightly. These decisions are hard to make. We're having this conversation because we don't have a patient. I don't have a patient going through it right now, but what if one day I had a patient that has been with me for 15, 20 years come and ask me this about this topic? I'm thankful that we're having this conversation so that I've thought about it and looked into it and can give them and guide them in a good direction. With that said, is there anything else you wanted to add from the legal side or anything from a lawyer that we should point out to the viewers and the audience here?
Your last comment about understanding what you need to be doing for your patient kind of triggered something else. And this is actually something that I did come across. There are instances in which doctors have violated Controlled Substances Act. And we have talked about it with the medical marijuana process, where you guys have to adhere to very strict rules and procedures when you're prescribing medication. So with adhering to those very precise rules and regulations, there are doctors who have considered or actually went through with prescribing lethal doses outside of what would normally be needed for that patient. And that has been a consideration in physician-assisted death, where you might not prescribe the same type of cocktail that's in MAiD states, but you're prescribing a more lethal dose of something they're already taking, knowing that it will ultimately lead to their death, and that's something that they want. And so that could also be something that stands out, as far as you owe it to yourself and to your patient to still adhere to rules and understand that you might think that you found a loophole, but there's other areas that you can still be held liable just by doing something against the law or doing something against policy.
And my final comment is that we haven't really touched base on what those medications are that are utilized in medical aid in dying. They're usually barbiturates. Barbiturates we actually commonly use as an anesthetic, as a sedative. Anesthesiologists will use it. But we also use it on the floor of the hospital. If the patient's having a seizure and we're trying to break the seizures, or if we have a patient coming in with alcohol withdrawal and they have a history of seizures, these are actually medications we normally go to and that we utilize for patients on a day-to-day basis. But it's when we use it in a higher dose that then turns it into a lethal dosage. That's where that nuance, even though these medications can be utilized on a day-to-day basis, it's those higher doses that qualify it for the MAiD program.
Final thoughts outside of the medical and the legal, from a lawyer perspective, and I want you to talk about your doctor perspective, but from a lawyer perspective, it's important to understand your rights. It's important to understand what's available to you. The one thing that's great about the United States is that we have instances in which the states might be divided, but there might be a way for you to get to a state that then adheres to your political stance or what you need out of life. There may be instances in which you might be in one state and think, okay, I need the access to MAiD, and you can find your way to another state. But before doing so, I always recommend that you just understand the laws, you understand the impacts, you talk to an attorney, you talk to your medical healthcare provider, and really become knowledgeable on it. Don't assume that it's a lost cause, and don't assume that you can just do whatever, because you can be putting yourself in a very, very bad place as far as criminal and civil liability. So that's kind of my last words. Dr. Long, do you have anything that you want to add?
I totally echo that. And that's why when it comes to any sort of medical decision or any medical treatment, if you have any second thoughts or hesitation, you should always get a second opinion. And that's why this whole process of medical aid in dying does require that you see two physicians, is because the more opinions that you can get, the more likely you will end up with the result that you want.
Well, listeners, thank you guys for tuning in. This was a more heavy topic, but we appreciate you guys sitting through it with us. As usual, if you have any comments, please leave them. Share, like, follow. We're on Spotify and YouTube. That's it for this episode of the Medico-Legal Brief, where medicine meets the law. I'm Lawyer Nik. That's Dr. Long. Thank you, guys. Yes, we're doctors. Yes, we're lawyers. No, this podcast is not medical or legal advice. Do not take anything we say as a reason to perform your own heart surgery, represent yourself in court, or diagnose your neighbor's rash. This is for entertainment only. Think of it like hanging out with your smartest, wittiest friends, not a substitute for an actual appointment. If you act on anything we say without talking to your own professional, that's on you. Seriously, don't do that.